Okay. Okay. So I think that we will now start with the group who has been able to join. We have still people who are joining. Please don't hesitate introducing yourselves on the chat box so that we can know a bit more of who has been able to join. So I'm going to now give the floor at the beginning of this presentation to my supervisor, Philippe Gasquet, for the opening remarks. And very briefly before we go ahead with that, I'll say my own name. My name is Paula Gomez. I am working at the Learning Solutions and Training team in Lyon. The team is part of the WHE. And I'll now just pass the floor to Philippe Gasquet, who will give a brief introduction about the virtual learning series.
Okay, thanks, Paula. Good afternoon, good evening, good afternoon, and good morning to everyone. We're very pleased to start this series of COVID-19 National Rapid Response Teams virtual learning. My name is Philippe Gasquet, as Paula introduced, and I'm the unit head for the Learning Solutions and Training team based in WHO. HQ headquarters in the Lyon office in France. And so, yes, this training is geared to people who are members or would be members of National Rapid Response Teams and addresses a few issues regarding COVID-19. So it is not a training on the specific issues that will be presented to you along the 4 different weeks, but actually more about the roles and responsibilities of members of the National Rapid Response Teams with regards to the various technical areas that we will address during the week. So today, the focus is on active case finding and contact tracing. So going back to the slide above, please. So the focus is really on the needs of National Rapid Response Teams and to meet the learning needs of National Rapid Response Teams arising from challenges encountered and in response to COVID-19 in the day-to-day activities. So we probably know that you have a lot of experience already in 6 months of combating this pandemic. And it would be interesting also in the same extent to get feedback on how you have addressed this and the challenges that you may have encountered. We designed during the spring and summer season a number of modules on COVID-19 for National Rapid Response Teams, and these modules are available on our learning platform, and they go a little bit more in depth about the topics that you will go through these series of webinars. There are additional topics at the same time, so we strongly invite you to take the time and complete the various modules that are offered to you, specifically in the areas where you feel like you need to intervene. And at the same time, I would also say in the other topics, because one of the key premises about the National Rapid Response Teams is that it's a team. It's a team of individuals with various specific competencies that are working together and complementing each other with various roles and responsibilities. So the concept of team is important, and understanding what other members are doing in the context of the team is also very important. The learning, as we propose it, is going to happen in 3 steps. The one is about, the step 1 is about acquiring and consolidating essential knowledge. The way this happens is through the modules, accessing the modules as individuals that we made available on the health security learning platform, and completing the modules as I've indicated earlier. And on the right-hand side of the slide here, you can see a little screenshot of the information about the modules, but we will also send you the information again in various contexts so that you can access the modules if you have not had the chance to do so until now. Step 2 is about building in-depth knowledge and apply this knowledge. And basically, these are what the webinars are about. We're going to review these key points. I mean, probably most of you are quite familiar with these, but the context of COVID brings new challenges. And so we'll see how, what are the different optimal solutions for applying various issues in the context of national rapid response teams. And the step number 3 is actually the follow-up. The webinar today is only a couple of hours. And so we have, at this point, as I speak, over close to 170 participants. Not everyone will have the chance to participate, to exchange information. And even though we are very much interested in continuing the dialogue and facilitating the sharing of experiences, of challenges that you have encountered, and facilitating some kind of peer-to-peer learning through what we will present in a few minutes, what we call the Rapid Response Teams Knowledge Network. So some of you may be familiar of these networks that exist already, that have over 500 participants in Anglophone and Francophone tracks, altogether over 1,000 probably. And so we will present to you what these networks accomplish and how potentially you can continue the conversations with people who are already part of the network if you're not already in the network. Next slide, please. So here is a quick overview of the various webinars that we will offer in the context of this series. So the first webinar today is on active case finding and contact tracing. Next week, and it's kind of like a systematic process where on Tuesday, basically, for Central European time, from 1 to 3 in the afternoon, we will conduct this a webinar on various topics. So today the case is about active case finding. Next week will be community engagement. The following week, occupational health and safety, and finally, data management and dissemination. And so now I just want to add a final comment here. Next steps in November, perhaps on topics that you might be interested in, we will consider these and how to move forward. And I want to, first of all, recognize the incredible work that has been going on in terms of preparing these, first of all, the modules that are posted on the Health Security Learning Platform and the various webinars here. It is truly about one WHO. It is with tremendous help from the Afro colleagues, from Emerald colleagues, from Sierra colleagues, that we have been able to put together the various series, and different people will come in the various hearings starting today from the different regional offices and with the support of HQ as well. Thank you.
Okay, so many thanks, Philippe, for this overview and this introduction. We are now going to go to the next steps. So now I'll invite to join us our colleague Katrina Litam, who is going to talk to us about the Rapid Response Team Knowledge Network.
Thank you, Paula. So good afternoon, good morning, good evening, everyone. I am Katrina Litam, as Paula introduced, and I work with Philippe and Paula from the Learning Solutions and Training team. So before we proceed with the webinar proper, I would like to share with you this visual representation of the Rapid Response Teams Knowledge Network, or RRTKN, which some of you might already be members of. So briefly, the RRTKN was established in 2015 to facilitate the exchange of experience and knowledge among RRTs as a follow-up after the RRT training done in the African and Eastern Mediterranean regions. So here we see the RRTKN is like a container where new knowledge is shared and generated through various mechanisms. We have some examples here, such as face-to-face training, pre-COVID, planned discussions, newsletters, and chat discussions. So how is the Rapid Response Team's global virtual learning series connected to the RRTKN? As Philippe has said, the webinars in the RRT-VLS are another mechanism by which we can contribute to the production of new knowledge or shared knowledge. Next slide, please. So during registration, you were pardon? Kindly keep yourself muted. Thank you. So during registration, you were asked what specific questions or issues you would like to see addressed or elaborated during the webinar. So the colored post-its here in yellow, pink, and blue contain some of your answers. Again, this webinar is an opportunity for participants and facilitators to look for the answers to these questions together. If unanswered questions remain at the end, then the search for these answers is continued through the RRT Knowledge Network. So I see someone, our colleague from Ghana has but at the end of our colleague from Ghana has shared a link to his own network. But at the end of this webinar, we will be sharing with you the link to the Rapid Response Team's Knowledge Network. Over. Back to you, Paula. Thank you.
Thank you, Katrina. And please, I do remind to everyone that you should keep your microphones muted. Yes, so that everybody can listen properly. Who is then not having the mic closed? So please keep it muted, because if not, it will be very difficult to follow the conversation here. So I'm going to go through briefly through the house rules for the participation to this webinar. Those have been already reminded in the house rules that were sent to you. But here, as I said just now, keep your microphone muted throughout, and please disable your camera video feed. And you can introduce yourselves on the chat box. You have already started doing it, and thanks to all for this. As it was explained to you when sending the reminder email, you will need to use your smartphone during the webinar, because we are going to have some activities that it will not be just a presentation by experts. You will be engaged in those activities, and for that, you need your smartphone with internet connection ready, and ideally able to scan a QR code, right? So if you don't have that yet, please ensure you can either download an application to scan QR codes, or use your phone, the camera of your phone. Sometimes some phones have this possibility. So, and of course, you can use the chat box to ask questions, to make contributions, ask clarifications, etc. And as Katrina just said earlier, the responses to questions that you will raise today, some of them we will be able to address them during the webinar, and some of them certainly not. I see that we are now 220 people together. So we have to anticipate that many questions will be asked, and probably not all will be responded to during the webinar. So So the knowledge network will be a space for us to continue the discussion and get some answers to the questions that cannot be addressed today because of the limited time, let's say. So now we are going to have all of you testing your access to an application that we call Slido, that is called Slido. And this application, we will be using it during the webinar for some quizzes and polls, etc. So I invite you all now to take your smartphones and scan the QR code that you can see on the screen. An alternative to joining with the smartphone is, or using the QR code is joining through the link that you can see here, slido.com, and yeah. So let's. I'm going now to give the screen to Silvio, who is going to manage the Slido test. So it's to you now, Silvio.
Hello, everybody. I'm Silvio Mena. I think I can see that some people are already sending their information. So I'm going to share my screen. So now we'll see who is with who. Yeah, I think you can see my screen. We'll take 1 minute, let's say, or let's see if we can have 100 people. That would be nice. 22 right now. Many people from Myanmar. Bhutan is also with us. Okay, 34 people replied.
Mute lami. Second speaking.
Okay. So this is really the opportunity for you to use this this application, because we will use it, as Paula said. We'll use it a few times during the meeting. So this is really the first attempt. So that's why it's good to have everybody connected. I mean, most of people right now. Take your chance. So 60 people, it's good, but it's not, we are currently, I think we are more than 200 people.
Yes. So how many people responded?
So far, 65.
Okay, so we see that Bhutan has a majority.
Yeah, we have.
As the majority of connected. Myanmar is getting bigger. So let's try. Let you try to put your country up, please. All those who are part of the webinar today.
We have quite different continents, huh? Trinidad and Tobago. We have St. Martin's. We have Botswana in Africa. We have Vietnam, Thailand, Bhutan, Myanmar. In Asia, we have Germany. We have the US. We have France, in Egypt, Turkey. So all over the world. Ghana.
Okay.
Sri Lanka, and apologies for those that we would not be quoting at this time.
Okay, so we need to test the application with this exercise that is quite nice also to see, because it gives us an idea of who is, which countries are represented here in the webinar. And then we will be using the Slido application for technical questions later on. So please, we are now 19 people who have been able to vote. Let the others please.
See, someone is drawing something on the screen.
Yeah. Can you please start drawing? Okay, you have that possibility, but please avoid, because it's not useful.
Okay, soon we will reach the 100 countries. So we have.
Okay, I cannot erase Silvio because you have the control, but it's okay. Doesn't matter.
Yeah. Let me see clear. Okay. Do you want to wait? Sorry?
No, I was saying almost half of the people are have been able to connect to Slido. Let us give just 2 minutes more to those who couldn't do it so far, so that they try.
Some more people from Timor-Leste. I don't know. We have Brenda also with us, Yemen.
Event code.
Okay, I hope I suppose that some people have difficulties. Really, if you can use your smartphone and simply type. If your camera doesn't, you use your browser on your phone, and you type slido.com.
Yes, I see on the chat box some people explain that they have difficulties in connecting. The event code is RRT, as you see on the screen. And in principle, it works quite well, either with the QR code or typing it on your smartphone as well. Slido.com.
So India is growing.
Okay.
So I think we have about 25 countries currently.
Excellent. Okay, so we may stop the activity at this point. But be ready again with your smartphones, because very soon we will use Slido again to respond to technical questions, okay? So if you want to be engaged, and we need you to be engaged in this webinar, that's the interest of it. So please be ready to contribute. 133 people out of 244, it's a very good rate so far. So let's move, Sylvia, with the next step of the webinar. Okay, thank you. Okay, so now we are going to enter into the hard content of the webinar. And as Philippe mentioned earlier, actually the webinar was prepared and will be facilitated by a team that is composed from colleagues, from WHO offices, regional offices from the Eastern Mediterranean region and the African region. So colleagues whose names you see here on the slide will be introducing themselves as they take the floor. So we will now start the presentation with Dr. Mohamed Tahoun. So Dr. Tahoun, it's to you now to take the floor. Can you hear us well, Dr. Tahoun?
Can you hear me now?
Yes, we do hear you well, I think. So
okay,
please,
thank you.
Thanks to you.
Thank you, Paula. So good afternoon, good evening, and good morning, everyone. As I could see, there are a lot of participants from different countries all over the world. So this is Mohamed Tahoun. I'm an epidemiologist working in the health emergency information and risk assessment unit in the WHO Health Emergencies Department. from in the Eastern Mediterranean Regional Office. I'm working mainly on the area of surveillance and response monitoring. So by the end of this webinar, the participants should be able to identify key challenges and solutions for effective active case finding and contact tracing during the context of the COVID-19 pandemic. Participants will also be able to use and adapt the appropriate tools for effective active case finding and contact tracing in the context of COVID-19. And moreover, the participants should be able to determine the roles and responsibilities of the rapid response team members, other actors in performing the case finding and the contact tracing within the context of COVID-19. So before we start defining the contact tracing, just why we do contact tracing. When COVID-19 started, there have been some interventions that were identified with the aim to break the chains of human-to-human transmission and to ensure that the number of new cases generated by each confirmed case is maintained below 1, which is also known as the effective reproduction number. So one of the most effective strategies to control the COVID-19 pandemic, this is the contact tracing and quarantine. So what is contact tracing and what is defined by what is the definition of contact tracing? This is the process of identifying, assessing, and managing contacts to prevent onward transmission. So this leads us to defining the contact. Who is the contact? What is the definition of the contact? Contact is anyone or any person with the following exposure to a COVID-19 case from 2 days before until 14 days after the case onset of illness, with the following conditions being, for example, within 1 meter of a COVID-19 case for more than 15 minutes, or has been in direct physical contact with a COVID-19 case, or providing direct care for patients or cases of COVID-19 cases without using the proper personal protective equipment. And sometimes there are also additional definitions as indicated by the local risk assessments procedures. So contact tracing, preparedness and readiness is different in different transmission scenarios. And as we all know, that there are 4 epidemiological transmission scenarios that have been proposed by the WHO, which are no cases, sporadic cases, cluster, and community transmission. In each, the contact tracing activities should be different, but for example, when there are no cases, we should be ready and identify the needed workforce and the contact tracers and train them in order to be ready to respond. While in the phase of the sporadic cases and the cluster transmission, we should ensure essential and rapid, the essential contact tracing is activities to ensure rapid suppression of the transmission of infection. Moreover, when we come to the community transmission, the contact tracing activities are usually becoming more and more difficult. So in such scenario, the contact tracing activities should be carried out as much as we can, with a special focus on households, healthcare workers, vulnerable populations, and closed communities like schools or elderly homes. So, and also during this phase, maintaining strong contact tracing is encouraged in cluster areas with which report small number of cases. So contacts, for symptomatic cases should be followed up from 2 days before the symptom of onset of the case and up to 14 days after their symptom of onset. So as you all know, that there are also a high proportion of COVID-19 cases that are asymptomatic, and their contacts should be followed up. All contacts should be identified, and those contacts who are in contact with the asymptomatic cases 2 days before through 14 days after the sample was taken, which led to the confirmation of the COVID-19 infection. So, and then this chart, this is an example of the contact tracing activities in a community setting. And as we can see that the cases, when a case is identified in the community, we should identify the contacts and list them and monitor them at least for 14 days. If no symptoms, then we can stop monitoring. And if symptoms develop, we should go to the usual protocol for management of COVID-19, which isolate, test, and treat. This is another scenario of contact tracing, which is done in the healthcare settings. Identify the contacts and monitor them for 14 days. And as previously, okay, if no symptoms, then we can discard. Also, one of the protocols is to test all healthcare worker contacts, regardless of the development of symptoms. And also, if the contacts develop symptoms, we should go to the usual protocol of management. So this is the end of the introduction, and now I will hand over to Dr. Tibel Chowri.
Thank you very much, Dr. Tahoun. It's to you, Dr. Tibel, now.
Okay, thank you very much. Can you see the microphone or not? Can you see the video around and the microphone is open? Hello?
Yes, all is good, Dr. Tibel.
Okay, thank you very much, everyone, and welcome to. This is an example from a country in the African region. And the reason we are showing this is, as you have seen in the previous slide, the community transmission. When the community transmission occurs, it is sometimes very challenging to do the contact tracing. In my experience, I spoke to some of the incident managers around, and I asked them, okay, how is contact tracing? Some of them turn around and, well, by the way, we don't do that anymore, or we stop it, or we do it partially. And I ask them question, why? Because community transmission. And if you look at the guideline, it is well outlined. You can still do contact tracing, even if there is community transmission. We took this.
Dr. Tibel, are you all hearing Dr. Tibel, or I am the only one who is not? Can you please respond on the chat box if you can hear Dr. Tibel?
Okay, he's back.
Yeah, can you hear me?
Right. Yes, good.
Okay, so I don't know who muted me. It was said the host muted. Okay, anyway, okay. The example comes from a West African country. And if what they come up with is when the epidemic started and they were doing contact tracing, individual cases, and follow all of the contacts. Then, because the epidemic started, the number of cases start increasing all over the place in the city, in different districts. They look at it, and the lockdown was implemented, and different measures were implemented, but yet the number were increasing. So they came up with community-based approach, which is the team, the rapid response team, we can call it extended rapid response team, will go to the family, and those families were identified by community health worker. So you register all the family in the city, and they will go there where the cases was identified and follow all of them, confine them. But by doing that, they have to test the suspected cases. and contact and isolate them in the house or in the health care center, depending on the severity. So you look at it, how many household they have surveyed or they have confined, 300. And containment were almost 1,000 active cases in the household. During the follow-up, they have confirmed almost 300 cases, which were transferred to the community, the treatment center. To motivate the community, to motivate individuals, they have to provide food and basic hygiene measure and other indicator. So the strategy, in fact, complement the other strategies developed by the country or adapted by the country because they work with the partner. The scenario here is this approach, community-based approach, during the lockdown was very effective. And now you need to think about this. If this is some strategy where you could use in your country context. But saying this, it does not mean it is kind of the black box. Everything is black and white here. But it is one of the best practice one could use to tackle the community transmission. But there must be some assumption and condition as well, because this was done during the lockdown time period when epidemic was increasing. Okay, next slide, please. We can move to the next slide, where there will be some question, and the question will be, if you could use the Slido and type, if you have to use this indicator, this strategy, what indicator would you like to evaluate? Because you all have been member of rapid response team or you have been involved in outbreak, but having this, yes, having this strategy where you think it is a best practice, and if you could list 3 indicators that you might want to monitor in order to evaluate the impact of such strategy. The country which has used came up with some indicator because they thought to be able to recommend this methodology, you really need to evaluate it in somehow. Please, if you could type in your Slido, I think that will be something very to look forward.
Okay, so you have now the QR code that appears on the screen. So you can scan the QR code again. And in that way, you will be able to access the quiz and respond to the question. The question is, please provide 3 indicators that you would like to see, to monitor, in order to evaluate the impact of this strategy in reducing the community transmission. Out of the many that you could think of, please try to keep the 3 key indicators you are thinking about. So for that, as we did for the icebreaker, you have to scan the QR code, right? I don't see anyone responding for now.
Yeah, not.
So can you use the Slido and the?
Yeah.
Okay.
Okay.
We start seeing answers. Good. number of new cases, number of tested for COVID-19, trend of illness with flu-like symptoms. We have percentage of cases with known sources of infection, percentage of cases coming positive of contacts, percentage of cases admitted as per protocol. Other proposition is tracing, isolate, and I lost it now, manage. Yep. So we are talking here about indicators, right?
Yeah.
3 indicators. Okay, so you can respond
Hello? Yeah.
to the 3 questions that are part of this example, associated to this example. You have the 3 questions that open at the same time when you use Slido. So the 3 indicators is the first one. And the second one is, what if the Stop COVID in 60 days strategy was recommended to be used in your country? What would be the advantages of such strategy, right? Okay, we have already quite a number of ideas expressed here. And then we have the third question, which is, what would be the disadvantages? Yes, so limitation of quarantine, the lack of isolation room, real time, these are the constraints. The lockdown strategies. Oh, it comes so quickly that it's difficult even to follow.
It's me.
So,
Yeah, I can
yeah,
see
just
it.
little. So people rebelling against restrictions, may not get accurate results, limited resources and exceeding expenditures. That's part of the constraints, yes. So can we, Dr. Tiebler, as we see the results, have some comments from your side?
Okay, fantastic. Maybe, okay. Yeah, hello?
Yes, please, go ahead.
Okay, yes, this is really very good. And we can see that there are different approach from country and from colleague as well, based on the experience. Because what's happening here, when this strategy was implemented, at the end, the country Ministry of Health and the response committee, they wanted to know exactly how they can use this strategy in the entire country, because they have tried in few districts and they found out it works, but how could they convince the Ministry of Health? They came up with some of the indicators. They developed 11 indicators. Maybe some of you touch upon those indicators, but because for improvement purpose, maybe some of the indicators you put can be considered as well, but the country came up with proportion of confirmed cases isolated globally. That's one indicator. The other one is the proportion of confirmed cases isolated at home. Remember, one thing is epidemic. Number of cases were increasing, and taking everyone to the healthcare center will be a burden. Maybe they don't get bed, that's one, and the resource as well. If you confine them at home, the advantage, if they comply, is you can look after them. Those critical ones, you can take them to the healthcare center. Those mild ones, probably they can be treated at home. And the response team, when we say rapid response team here, you have psychologists, you have risk communication expert, epidemiologists, even case management, they all can come together. And so that's the interest. That's very interesting for that. So you need the proportion of confirmed cases isolated at home. Then you need the proportion of cases transferred to the COVID treatment center, which is an important indicator as well. You need a proportion of hospitalized, you can say, between bracket and the treatment, not transferred, and proportion of cases isolated at the treatment center is another one. Proportion of confirmed cases isolated within 48 hours, proportion of confirmed cases investigated, proportion of contact follow-up. If all these are good indicator, you might say, well, we can recommend this strategy, but don't forget the lab component of this. Sample collected between specifically the last 2 days of follow-up, which is 12 to 14 days. Then the proportion of non-contact confirmed is another important indicator, and proportion of household provided with basic PPE and sanitation kit and good. If, for example, you have a problem of doing this, maybe they will not comply. And if they will not comply, then your contact follow-up in the community and the community participation might not be good. This is, hello, can you hear me? This is
Yes.
a strategy where you need really community participation, and some name it participatory disease response. So it is, again, a multi-sectoral approach. You can even call it One Health approach here, because based on this, you can even sample the animal in the house. Okay, over to you. If you got any problem with this indicator, you can, I think Paula will share with you, you can give feedback, but then the next question, Paula, you can project it down so they can see that, please.
Yes, thank you, Dr. Tiebler. Actually, we did see the three questions that were the answers to the three questions that participants responded to. We have now for the question 2, let's say, we have the advantages, and there are many responses about the advantages. And now we have just a couple of minutes to wrap up on these questions. Yep.
Okay, thank you again. Some of you mentioned it, if it is a conflict area. Yes, indeed, a conflict area, it might take some negotiation, but I don't think anyone wants, whether you are in a conflict or not, if you wish to get sick, especially with disease which less is known about, and you get infected, some are asymptomatic, but some are symptomatic with serious consequences. It can be long-term consequences. And these are things, factor which you need to take into account. And the strategy, the advantage could depend on country context, but they do have some constraint as well. You need to have a resource for this. You need discipline and comply. If they don't comply, you might fail. And that's one. And community might just stigmatize families as well. And the collaboration of community leaders are key here. But the strategy involves multiple sector, and it involves rapid team going straight on the ground and work together, and they might come to the challenge, across some of the challenge, they might negotiate and deal together, increase the experience and to tackle further disease, even if outbreak happen. And those are, but again, it depends on country, but you can take this and think about it, whether it can be applied for the community transmission. Okay, over to you because of the time. Hello.
Okay, so here the response is about the constraints of such a strategy. So please, the question has been raised on the chat box. The questions and answers with Slido will also be shared with you all after the webinar. So we have some more time to review the various strategies proposed here by the colleagues. So any final word, Dr. Thieble, on the constraints and the responses you see here on the screen?
Yeah, I can see a lot of good response here by all turnaround, resource constraint, we know that mental support. Yes, in the team, you will have people expert for the mental support. Because what happened here, if the team is composed, well composed, as you have seen when Philippe and colleague were mentioning rapid response team, and you know the relevant team member can be deployed in each location to work together, and that will make it easy to tackle the problem. But again, this is called, you need extended rapid response team, where you can have even community leaders. And so those will facilitate. But again, the constraint will come with the community acceptance. Because if they don't accept it, that will be a major problem. But economically, it should help, in fact, reduce the economic burden. For example, the number of beds needed in the healthcare center. If you can confine them at home, you might benefit a little bit on that. But yes, in fact, you need money to be able to support. But once the strategy is working, maybe community volunteer and partner can come up, can step in to lower down the cost to the government as well. Okay, thank you.
Thanks so much, Dr. Thieble. Thanks. We are now going to get back to the presentation. This was actually an example that was shared by Dr. Thieble from the African region to launch a bit the discussion on the topic on active case finding and contact tracing and possible strategies that can be taken based on the content, on the context, on the resources and other factors. So now I'm going to give the floor to the Dr. Shireen El Nasri for the next steps of the presentation.
Thank you, Paula. Good evening. Can you hear me?
Yes, I can hear you.
Okay.
Yes.
Active case finding. Okay, thank you.
Good. No. Shireen, can you hear me? We are not hearing you. I am not hearing you anymore, at least.
I think you need to unmute.
Okay. Yeah,
okay, thanks.
I was muted. Okay, I was muted. Sorry for that. Active case finding and contact tracing are essential public health tools for controlling any outbreak. Different strategies can be used to conduct active case finding, either actively through interview with known cases to identify the contact, house-to-house search, visit health facility to review hospital registers, visit private practitioners, traditional healers, pharmacists, and labs, Systematic case finding in closed settings such as residential facilities, or can be done passively through routine surveillance and enhanced surveillance, rumors hotlines, public information messages in the affected communities, and engage community leaders, volunteers, health workers to report cases. Next, please. As you mentioned in the previous session that contact tracing is a challenging process. It is a resource-intensive activity that required a lot of financial and human resources to deploy an army of tracers to identify and monitor contacts. It generates a huge amount of data that needed to be compiled, analyzed, interpreted, and stored in a suitable way. Identifying contacts might be challenging as well. Cases usually reluctant to provide information regarding their contact, sometimes because they simply forget or they don't perceive the importance and benefits of contact tracing. Lack of trust and fear of stigma are another reasons. Contact tracing requires to agree to daily monitoring, to be willing to report signs and symptoms promptly, to be prepared to go into quarantine for at least 14 days or into isolation if they become symptomatic. The way the information is communicated and shared with contact will affect their perception and might lead to community resistance. In some settings, language and literacy could be a barrier. Long follow-up period leads to fatigue and loss of follow-up. That's why some countries are reviewing their contact tracing duration and trying to shorten it. But up to now, the guidelines from WHO, it's recommended to follow up contacts for 14 days. However, there is some discussion, and if there is any update of the guidelines, we will share it with you. Another issue is contact of asymptomatic cases. Although it is recommended to follow up them, but it is hard to convince people to be followed up. Next, please. Challenging also appears in managing contacts. What are the effective placing, either in home or quarantine facilities? Facility maintenance in terms of staffing, equipment, and supplies, especially IPC, might be difficult and resource intensive. That's why many countries recommended home quarantine. But again, the support needed for the quarantine persons in terms of financial, social, psychological, and providing the basic needs. Compensation for the loss of income might be an issue that lead to lack of compliance. Appropriate referral mechanism in place might also influence the contact tracing. Concerns regarding the tracing team, like physical or security inaccessibility to some places, limited resources, and infection among the team. Ethical consideration in terms of privacy and data protection, and delay in obtaining lab confirmation results that lead to delaying confirmation of the cases and a delay in initiation of contact tracing as well. Next, please. Contact tracing depends on availability of resources, and it might differ according to different settings. In high resource settings where there is robust public health infrastructure in terms of workforce, supplies, strong lab network, intensified contact tracing efforts should be implemented. Quarantine could be done in facilities. Even more testing of asymptomatic cases could be done to increase our knowledge about the new pandemic COVID-19. However, in low resources countries, contact tracing should be continued as much as possible. If not feasible, contact should be assessed and prioritized. Regarding closed settings such as prisons, IDP camps, residential facilities, or schools and universities, where there is a probability for transmission, where the probability of transmission is higher than general population, contact tracing efforts should be intensified. Next, please. So what are the solutions? There is no easy answer or one strategy that fits all. Countries may need to tailor different aspects of contact tracing according to their capacity and epidemiological situation. In scenarios where there are low number of cases, contact tracing is usually undertaken by using existing public health structures. All cases are usually interviewed within 24 hours of being diagnosed. All contacts are listed and follow up on a regular basis, and all symptomatic contacts are tested. However, with increasing number of cases, an adopted model is needed. After containment and de-escalating phase, a robust contact tracing strategy should be resumed. Next, please. One of the available solutions is to scale up contact tracing by using non-public health staff and volunteers such as students, retired care professionals, NGOs, workers. But again, they should be trained and under full supervision of rapid response team. Using of existing resources, like using of existing call centers hotlines and repurposing existing staff, reinforcing by volunteers could be done. Reducing the intensity of follow-up of the contact, including prioritizing contact, follow-up high-risk contact, texting instead of calling and visiting, and encourage self-reporting could be a possible solution. Next, please. Good preparation and planning by estimating the required resources for contact tracing. There are different tools available to estimate the required resources using different parameters to estimate the number of contacts, duration of interview, and needed supplies. WHO has developed a tool that estimates the number of contact tracing needed to identify and trace a specific number of cases. This can be calculated for a single day or over a defined period. And you can find here the link for these tools in the provided slides. Next, please. Many digital tools have been developed to assist with contact tracing and case identification. These tools include outbreak response, proximity tracking, and symptom tracking tools. Outbreak response tools are designed for rapid response team involved in contact tracing activities and outbreak investigation, like GoData. GoData tool can be used to facilitate all aspects of contact tracing, including case investigation, listing and monitoring of contacts, and analysis and performing visualization of chain of transmission, and data can be exported and shared and analyzed using different softwares. Proximity applications. Several countries develop proximity application using location-based GPS or Bluetooth technology to find and trace the movement of individuals to identify people who may have been exposed to an infected person. Although there are some ethical considerations, the use of mobile contact tracing app for contact tracing offers several benefits. They don't rely on the memory of the cases, who may be very ill at the time of interview. They allow contacts unknown to the cases to be traced, like fellows and passengers who sat close on the train. They can potentially speed up the process. However, the effectiveness of proximity trackers remains unknown and more researches are needed. Symptom tracking tools use applications designed to routinely collect self-reporting signs and symptoms to assess disease severity and probability of infection due to COVID-19. These tools may be helpful when integrated into contact tracing, especially in settings where there are physical or security barriers to in-person visits by contact tracing team. However, there are challenging aspects to symptom tracker tool that must be carefully considered, such as limited specificity and positive predictive value for respiratory infection, potential for misdiagnosis and non-diagnosis of other illnesses, and the need for users to know how to take actions and seek medical attention. For these reasons, self-reporting of symptoms can never fully replace the need for dedicated contact tracing team. Next, please.
cannot hear you. Shireen, you are muted again.
Okay.
No.
Can you hear me now?
Now it's
okay.
good.
Yeah. Okay. So contact tracing begins with engaging communities. There are some recommendations that might ensure sensitization of the community, like training contact tracer in effective communication skills, recruiting contact tracers from within the target communities in order to maintain trust, establish multi-sectorial and multidisciplinary contact tracing team to support community engagement where possible, develop messages and talking point ahead of time to support the contact tracers in their ability to communicate with public, conduct awareness raising campaign within the community or population where transmission is ongoing to explain the importance of contact tracing and sharing information, provide reassurance to the target group that contact tracing information is protected and kept confidential. Next, please. Taking cultural practices into consideration when hiring contact tracers. For example, female contact tracers could interact with female contact in conservative communities, using influencers and popular personality to address stigma against COVID-19 and establish feedback and active listening mechanisms to learn about the concerns and questions about contact tracing practice, including social media, media monitoring tools, as well as national and local hotlines. Next, please. To wrap up, what are the rules of rapid response team in active case finding and contact tracing? Rapid response team should investigate cases and clusters of COVID-19 within 24 to 48 hours after reporting. Rapid response team should actively find the cases and should initiate contact tracing, train, and supervise contact tracers. Thank you. And now we will move to question and answer. Yes. Kindly put your question in the chat box, and we will try to answer it during this session. And if there is no time or the time didn't allow us, we will communicate with you by emails and share the answers. So kindly put your questions, queries in the chat box. Thank you.
Thank you very much, Dr. Shireen, for your presentation. We have now at least a good 10 minutes that we can use for addressing questions that participants were started already to raise in the chat box. So yes, so you can probably look Shireen and team to the questions and probably try to group some of the answers. So it's now to you for sharing your input based on participants' questions on the chat box. So I see that we have a number of questions here. I don't know which one you want to start with. Dr. Shireen, Dr. Evans, Dr. Tahoun, Dr. Tiebler.
Yeah, can you hear me? Yeah.
Yes, please go ahead. So which question do we like to address, Dr. Tiebler?
No, someone just asked a question about can you send us tool to develop workforce estimate per population, per district, and so on. And others have asked about the tool. I think probably for those who had a chance to look at the online material, for those who had a chance to look at the online material and training material for rapid response team, you might come across some of the tools Dr. Shireen just mentioned. And those are, for example, case investigation form and contact and the follow-up and those will facilitate the aggregation and for the further analysis. And you can always get the population data on the UN website or statistical office in your respective country. Okay, thank you.
Okay, thanks very much, Dr. Diablo. Just while Shireen, Dr. Evans, and Dr. Mahmoud are preparing for next answers, I just take a minute to say to everybody that the presentation will be shared after the webinar. Of course, we will also share the record of the webinar, audio and video, and any additional resources that might be available after the end of the webinar. So who then from Shireen, Dr. Dahoun? Yes?
Maybe I can kick off again for some of the
Yes, no problem.
questions. So Shireen and my colleague can prepare. And you have some issue related to the Go Data or DHS2 tracker. You have also polio tracker and different mobile tool developed by NGO and school, university, and all worked at a certain level. But then you need to train staff with passion as well. And of course, you need resources to mobilize them, to sensitize them. Then the resources become important. But the convince staff to know their role and to pay their dues to public health is very important here. Because when you love something, you see the benefit, you are more engaged to it. Of course, those who employ them need to look after them as well and not to destroy the resource for all. But all these applications are very easy. One of those applications, which is Go Data, it has been used in emergency situation like Ebola and country which have used it. They came up with a good chain of transmission. You can detect that, and the tracker can give you that one as well. Once you have the DHS2, you can even integrate both. So that was a concern. You need time and resource, but human is resource capital for all this. The training, you need good training and people engage into that training to learn it and use it for the benefit of the population. Okay, so to answer that question, someone asked again, what is the role of contact tracing at the stage of community transmission? Contact tracing, if you look carefully during community transmission, as it is stated in the guideline, you should not stop contact tracing because some people say, well, don't bother. No, you have always, when you do the risk assessment, you will have some higher risk transmission area of high level of transmission and some probably low. And you might try to focus on those high risk or moderate risk and just take off resource. Otherwise, the best option is to try to stop it. And one of those is to adapt or develop strategy. If you don't have it, but if other countries have used it, maybe you can adapt to some of those strategies. Because at the end of the day, you cannot control any disease if the community is not involved in. That needs to be clear to everyone. The community needs to accept it, be involved in, be part of it. And then you come up with victory. Okay, and it doesn't matter whether it is Europe or Africa or South Asia, this apply all over the place. And okay, then I stop that again for colleague.
Many thanks, Dr. Tiebler. Actually, there are so many questions here that so we are also having colleagues from the regional office from EMRO who want to come in to address some of these questions. Just for your information, we still have 4 minutes to address questions. So please, please feel free, Dr. Amjad, Dr. Shireen, or others to take the questions.
Okay, maybe I will start with some points. There's a question about the difference between contact tracing and case investigation. I think from the names or the terminology you are using, case investigation is for the cases themselves, to know more about their history of exposure, to know more about the clinical pictures, to know more about demographic information, including age and sex, just to understand more about the disease and who are on high risk to get the disease. That's the aim of case investigation. For contact tracing, the issue is different. We are dealing with healthy people, but they have history of exposure. We know not all of them will be converted as a cases. Maybe none of contact of some situation will be converted to cases. So the aim of contact tracing is early detection. There's another question about the role of contact tracing during community transmission. Of course, contact tracing is very important for 2 reasons. The first is to early detection, which will improve the case management and will, for sure, will reduce the case fatality rate. On the other hand, the early detection will help to early isolation of the cases, which will limit the possibility of transmission and increasing number of cases. In case of community transmission, the role of contact tracing remain important, but sometimes it became so difficult to implement. So based on the applicability and the possibility to continue with contact tracing, the health authority should decide. It is not possible to continue. In that situation, we have to focus on a specific situation, specific areas or a specific high-risk group. For example, if this village, camp, school, there's no any cases reported from that area, and one case start to report, we have to activate or continue contact tracing in this place. The first cases of in closed area should be followed by contact tracing. The same like healthcare workers, we should continue even in the community transmission scenario. Over to you, and I will review if I have to comment on any more question. Thank you.
Okay, thank you.
Many thanks, Dr. Amjad. Yes. So, who's Dr. Tahoun? You want to come in?
This is Evans here. I'm using Tahun's computer.
Oh, okay. Sorry. Please go ahead.
Yes. So just a few questions, which I came across. Maybe I can assist. There was a question about if the person we are, investigating cannot answer. Maybe they are quite unwell. You can, ask questions to, for example, the caregivers can be a useful source of information. The person who stays or lives with this person can provide you quite a good amount of information about the contacts. So if the person who you're doing the contact tracing cannot speak for any reason, you can always do your investigations using the others who are available. In terms of the follow-up period, for now, at least the WHO guidance, we still are at 14 days for the follow-up period. Discussions are going on in terms of how this, if or how this can be varied, the 14 days. Although different countries are adjusting on their own, some to 7 days, some to 10 days, but the current guidance from WHO still remains 14 days of follow-up. Now, there was another question regarding, estimating workforce. Yes, there's a tool which was developed by WHO colleagues in the Euro region, a fairly simple tool based on Excel to estimate workforce. I probably will share it later, Paula. We can provide the link later on that, but there's a tool which is quite good at estimating a workforce required for contact tracing. Lastly, there was a question also regarding, Go data in low resource settings. At least from the region we are in now, in the Eastern Mediterranean region, we have used it in
even in complex emergency settings, for example, in Yemen, even in Syria, and the colleagues there say it is working quite well for them. So it definitely can be used in low resource settings, the Go Data application. Okay, I will stop there and another colleague can take over.
Thanks very much, Dr. Evans. We can take one additional question probably also, but then move to the next step. And we can also think about and at least share some experience that are shared by our colleagues in the chat box. We have an experience from Bhutan that's shared on the chat box. They have an application called Drug Trace for easy contact tracing, and there is a barcode that the person has to show a scan whenever she or he is visiting any other place or institution, and this is mandatory. So it's like a proof of the visit, and if later the person is detected to be COVID-19 positive, the records can be used to trace the place of the visit and the contact. So that's a quite interesting experience that was shared by one of our colleagues here in Bhutan. Thanks so much for sharing your experience. So, and can we take one last question from the chat box and then move to the next?
Okay, Paula, there was some questions related to the contact tracing apps and the outbreak response tools like Go Data and the symptom checkers. All these applications are used by different countries and for contact tracing, for facilitating the process of the contact tracing. Regarding Go Data, it is open source, and it could provide storage for the data, and also could provide analysis and indicators, and you could also generate a contact follow-up list and a lot of other indicators. So and it's free. Just it needs some training, a basic training, and a server to host the program on it, and it could be ready for deployment. This is regarding Go Data. Another question was about the symptom checker. Yes, this could be used as well. However, it has the disadvantage of being non-specific. So people should be alert and should be well informed about the symptoms that they should report. Otherwise, you could receive a large number of noise about each and every symptom that anyone may complain from. So for these three categories of applications, each one has its pros and the cons. However, the main objective is to facilitate the process of the contact tracing and to carry it, and as it has always been said, and it's known that the contact tracing is a resource intensive process. Even a minimal contact tracing could prevent a large number of transmission.
Thank you very much, Dr. Sadek, I believe. So that's okay. So that's not the end of the discussion. As we said earlier, we see still in the chat box a lot of questions that are there and experiences that were shared. So let's move to the next step of the webinar, but keeping in mind that questions that were not answered or insufficiently elaborated will be we will have a chance to continue those discussions on the Rapid Response Team Knowledge Network, and we will provide you with the information for you to join that network if at all you are not part of it at this stage. So here we are going to have a case scenario, and this case scenario, our colleague Dr. Evans will be facilitating it. You will see that you have, first of all, an initial situation and then a set of questions that you will have to respond to using Slido, as you have done earlier. So Dr. Evans, is to you now.
Yes, thank you very much, Paula. So yes, welcome again, colleagues. So my name is Dr. Evans Bolivar. I'm a technical officer in the Health Emergencies Department at WHO, Eastern Mediterranean Regional Office, EMROM. So we'll take you through this case scenario just to refresh what we've been talking about and see how it can be applied. It is there on your screen. I'm sure you can see it, but let's just read through it together. So it states that on August 15th, a new COVID-19 case has been identified from Central Hospital, CH, among healthcare workers. So this the case is a male nurse working at Central Hospital in a surgical unit, aged 35, and complained of fever and a dry cough and was subsequently tested for COVID-19. So his test results returned positive on August 17th. However, his condition deteriorated and he was admitted to Central Hospital on 20th August with pneumonia and severe respiratory distress. The case used the hospital bus to reach the hospital as usual from 15th to 20th August. His wife accompanied him to the hospital on 20th August. Their 3 kids stayed at home that day with their grandmother, aged 65. So that's the scenario. Okay. Maybe another few seconds, you can read it again. Maybe jot down a few pointers from this scenario.
So we will have the scenario that will be repeated just before the questions. So yes, thank you, Silvia.
You're welcome.
So please, colleagues, let us now all join the Slidos using the QR code and scanning it to access the quiz. Okay, so you can scan the QR code or type the slido.com in your mobile or even in your computer in another tab. So here you have, first of all, a reminder of the scenario. And I think that for this scenario, Silvio, people are requested to enter the name, right?
At the beginning, yes, but we had the name for all. I just click next. Okay. Don't worry about that. We'll see anyway. It's true that at the end of each question, we have a dashboard. So if when people reply correctly and very fast, they will be on the top of the dashboard. So we'll see that every time.
So the question is, at this point, what do we know about the case, right? What we know about the case is already here in the situation, but we have to really pay attention of what is known or what is not unknown or not known at this stage. So let us quickly respond. I see 30 people already responding. And we have to select all the questions that apply, right?
Yes.
Good. So, Silvia, do you think we can?
This is really okay. Maybe we can see the next one. Okay.
We can have a look at the responses. And
okay. Sorry.
Great. So just for everybody to know that for this exercise, we will be having some feedback from or comments in terms of the answers from Dr. Evans after each question. We have a set of 7 questions that we are going to respond to. And after each question, Dr. Evans will address what needs to. So let's leave it a bit of more time for people to respond. We have 55 people who were able to respond at this stage. So,
sorry, I showed the right answer anyway. They are in green. So maybe we can already have feedback on this one. I don't know.
Yes.
Okay. Because I see this
Okay.
71%.
Yep.
Yes, so the scenario we shared about this case, which has been identified at the Central Hospital on August 15th, that is when this case was identified. And it's a healthcare worker, as we know. He's a male nurse working at the surgical unit in this hospital, and his age is 35 years. So of course, male, age 35 years, that one we are correct on that, and most of you have actually said that. And it is actually a confirmed case because we know that his test results turned positive on August 17th. So it is really a confirmed case, and it was notified through the system. This case started fever and cough on August 15th, and then developed severe symptoms on August 20th. Okay, so his condition deteriorated, and he was admitted at the Central Hospital on August 20th. So on August 17th is really when his results turned positive, but he was admitted, a few days later when his condition deteriorated on August 20th. Okay, so I think the first one is correct. Most of you have got it. The second one is correct. And then also the third one, you have actually noted that he got to us on the 20th, not on the 17th. Okay, and then the laboratory results are the ones which came out on the 17th, and almost all of you are correct on that. Okay.
So just if I can, sorry, Dr. Evans, if I can just add, so exposure or travel history. So the correct answer here is that actually there is exposure because the case being a healthcare worker, right? Not because of any travel history that was reported on the case, but yes, because of the case being a healthcare worker.
Yes, that is correct. He's a healthcare worker. There was really no travel history in this case. He's a healthcare worker in this hospital. Okay, so hello.
Let's move to the second question, Sylvia.
Yes, please. Yeah.
Okay. So now the question is different. The first one is, what do we need to know? Now we ask the question, what do we need to know? Not what we know. What do we need to know about the question, about the case? And again, we are showing the scenario again to you all for a refresher about the information so that you can figure out the information that you need to get about the case. Okay.
Paula?
Yes.
Yeah, in the chat box, colleague indicating that they cannot vote and enter. Maybe probably if they vote quickly, that may be the solution.
So now for the for the second question, Sylvia, can you move to the second question? Okay. So the vote is already closed for all questions, Sylvia?
Nope, no.
No, so you can scan the QR code that you see in front of you, and please go ahead and vote, respond to the questions. You can still do it.
Yes, you can access the second question.
Yes, not the first, true, because we have to be quick in this exercise. But the second question, you can vote.
And I will show very soon the right answers.
Yes, let us give the people the chance to vote. And then question 2 is also closed. Silvio, we have people reporting that question 2 is closed.
Oh, it means that they arrived too late, unfortunately. So I cannot. It is open. I'm pretty sure because I see the score. We see 28 people now.
Yeah, but the score has not moved for many minutes. So can we reopen? Yes, if it's possible. So this is for question 1. Fine.
It's blocked.
Can you just erase the information and put the questions again?
Can you repeat, please?
Is that possible to erase the votes and start it all again?
I can do that. Okay.
If it is possible to do it quickly, it would be nice to have the possibility to vote, because if not, it will be the same for all questions. Just hold on for a couple of minutes. We will restart the quiz so that you can all vote. But just be aware that you have to be quick anyway to register to the pool, because if not,
okay.
Yes. So let us start the game.
So we have 80 people.
So let's scan the QR code here. Could you please close your mics, those who are speaking? Okay. Okay, now it is open again for answers. Excellent. 69 people already answered. Let us leave it at the minimum up to 100, huh? Minimum. Okay. Okay, so we are, as you understand, we are restarting the entire quiz to give the chance to everybody to be registered on the quiz and be able to complete the following answers, right? So,
I think
Silvio,
96. Do you really want to wait? 97?
Yes,
3 more?
We want to have people engaged. So you have to stay with us during the webinar. If not, you will lose the opportunity of learning new things.
99.
Yes.
Yes.
Yes. 100. So let them continue voting, because we want the most of the people to be part of it and enjoy this activity and learn out of it. Okay. Okay, so now the vote is closed, Silvio, or yeah?
Let's see. Okay. So this is for the first question. Let's go for the second question, I think.
Yes, we can move to the second question.
Maybe I can.
So now we have to scan again.
No, and you don't need to scan again. You go to the next question.
Right. Thank you. So the question is, what do we need to know about the case, right?
Exactly. So here it is, in addition to what has been presented in the scenario, as we are, doing further investigations, what else do we need to know in terms of workers' contact tracers for this case? So what else do we need to know? And you're supposed to select the correct answer. I think you'll put up the answers, Paula.
Answers? No, we don't have the answers. Oh.
$56. Let's wait.
Okay, so yes. Let you all engage as much as possible on this activity, which is really useful. Okay. Okay, we see people asking on the chat box how to answer. You just have to scan the QR code that's on the screen. And please, could you close your mic, those who have the mic open? Thank you. Okay, good. So let's go to the, so we have the answers now. Let's close the vote now for question 2.
So we see the result.
What do you think, Dr. Evans?
Yes, very, very, I see good responses which have come out of this question here. So what else would we need to know, in addition to what is presented in the scenario to help us, understand this case better? Okay, the first one, background info, has the full report been collected? Was he reported as a suspect case first? These are quite important questions which we need to know. Remember that really he fell sick, and then on the 15th, and the results came out on the 17th, and in between we really are not sure what happened, whether he was reported as a suspect case or not. We are not sure about that, so this is important information we need to really pick from this. So that's okay. And the second one, where does he live? I would say probably we need to know much more than this, than just where does he live. Can he be contacted, and who he lives with, who is taking care of him, who else is in the household? Are there other relatives, other people who came in contact with him, and really who is in his household? So we need to go just a little bit deeper than just finding out where he lives. I know it is important, but probably to go further than that would have been more useful than leaving it at where he lives. In terms of the clinical information, yes, we need to get more information. Did he take any medications, and which medications did he take, and how is his condition now in terms of severity? Does he need admission, and things like that? So we need to know all the clinical features of what is going through. The exposure, did he travel? Again, the question here was, who is his supervisor? I'm not sure that would really help to know who is his supervisor, but most important are who are his contacts, who does he work with on a day-to-day basis, maybe in his in the unit where he works, and was he isolated, for example, when he was suspected, and where was he put for the isolation? And we also need to know if PPEs were available, and if his co-workers did use this. and the healthcare workers who, you know, are in contact with him, whether they did use the PPEs. So most of you really managed to pick out that while the question is who is the supervisor, but we need much more than that in terms of the contacts. Even patients could have been in touch with him, and where he was isolated, if he was isolated, and if PPEs were used or were available or not. The final one there about laboratory, again, a very important question. What sample was tested and where it was tested? So this is an important question also, which most of you have picked that one out. As you know, there are different testing methodologies. Some are using the PCR. A few other, you know, countries are using rapid tests. So those are the various ones which are available, and where this test was done also, and the kind of precautions which were, you know, taken at the time of sample collection, sample testing. Also, that is important. Okay, over to you, Paula.
Yes, many thanks, Dr. Evans. We are now we are a bit ahead of time. Yes, so we are going to take at least 2 more questions for the case scenario with the debriefing. These questions are a bit quicker than the other ones. So this one is a true or false. The tools to be used to collect information about the case investigation form, and line listing. Is that true or false? I repeat, the tools to be used to collect information about the case are case investigation form and line listing. These are the basics. So it should be quickly responded to and addressed. So we have now more than 95 persons who have responded to the question. Okay. So Dr. Evans, what do you think about the responses here?
Very interesting, actually. Of course, an investigation is done, and you do collect information from your investigation. So in the sense of the approach that is taken, what is done is correct. You do an investigation and you do a follow-up. Although the correct, shall I say, name of the form is a contact listing form, and then you do the contact follow-up form. So a contact listing form and a contact follow-up form. But I see our colleagues appreciate that you have to do some form of investigation, and you have to record these contacts in some you have to get a format to record these contacts. But shall I say, the formal name would be a contact listing form and a contact follow-up form.
So at this stage, we are talking about the case, right? The tools to be collected to collect information about the case are case investigation form and line listing. Is that correct or not? We are not talking yet about contacts. Yeah. So Dr. Evans, is that, are we comfortable with that? Because the majority of people responded, this is true. Huh? Is that
Okay,
right or
I think
wrong?
I was on the next question.
No.
Sorry, I was on
Yes,
the next question. I jumped one. I was one ahead. Yes.
Okay.
So yes, the tools used to collect information about the case investigation form and line listing. I jumped one ahead.
Good. Let's jump to the next one now. Sylvia, let's go to the next one.
Okay.
Okay, you can go to the question directly. So now the question is, I mean, yeah.
You want to go back? Yeah, sorry.
No, it's okay, it's okay.
Okay.
The tools to be used to collect information about the case contacts. The case contacts are contact laboratory testing form and contact follow-up form. Is that correct or not? So we are now talking about the tools needed to collect information about the case contacts, okay? And we say, we don't see anyone responding here. The voting is closed. Silvio, we are moving.
No.
Okay.
Maybe I should stay here. Okay.
Yeah. Okay. So can you try again the vote if you can? Yes, you can do it. It's not closed yet. Sorry for the small hiccups here and there.
I've actually addressed this, so it should be quite straight because I've already addressed it in a way. Yes.
I think so.
Definitely. Okay. So now the vote is closed, right, Silvio?
Yes.
Okay.
That's interesting.
Oh. So how can we address and emphasize the right message here, Dr. Evans?
Okay, let me just go through once again these two questions. Okay, so the one before this was about the case. Okay, and this particular one is about the contacts. Okay, case contacts. Okay, so when you are investigating cases, okay, that was the previous question. When you're investigating cases, you do your case investigation form, and our colleagues who are doing rapid response teamwork know this very well. And you list your cases on the line list. So this is the normal work we do when we're doing the AP investigation of cases. Again, a repeat of cases, you do the case investigation form and you line list your cases as part of your investigation. Now, when you're, shall I say, investigating contacts, so following up contacts, remember the contacts are still not yet cases, isn't it? You're following them up, but they are not cases. At some point, they may become cases or not, okay? So when you're following up the contacts, okay, you use a contact listing form, and then after you list them, again, there's a contact follow-up form of which we'll use for the next 14 days to follow up these contacts. So you have a list of them written out, and then you follow them up on the contact follow-up form. Okay. So this particular question here, which is on the screen, asking the tools to be used to collect information about the case contacts, the contacts. Okay, it says here laboratory testing form and contact follow-up form. So the second part of the answer is correct in terms of there's a contact follow-up form, but the first one would really be the contact listing form, the contact listing form. Okay, so this is the way it is addressed is not correct. It should be a contact listing form and a contact follow-up form, not a contact laboratory testing form. Over to you, Paula.
Many thanks, many thanks. So let's do a final question, Silvio, the next one, and then we will wrap up because the time for closing the meeting is coming very, very soon.
Just so you can see the leaderboard.
Okay, so we have as the first person who on the leaderboard is Pasang. Then the second one, sorry?
Congratulations.
Yes. The second is Chone. The third is Notamanzo Kakalushi. Sorry for not pronouncing properly your names. My apologies. Then the fourth person is Caroline Franco. And then the fifth one is, Chucky Dolka. So congratulations to you all. and even to those who are not part of the leaderboard. So, because we are doing well. So let's have just a last question and then we wrap up with the scenario. So the last question is, where are the most concerning points of possible exposure in the scenario above? So let us leave the scenario here so that people can go through it very quickly again. And then please respond on the most concerning points of possible exposure. There are more than one, I believe. Yes, and as an addition to that, some people who didn't manage to connect to Slido are voting through the chat. So thanks to you, and that's a good idea to put your answers on the chat box if you have not been able to join Slido. So that's a great way to still contribute to the discussion. So let's have a look at the results, Silvio. So the most concerning points of possible exposure in the scenario above. We have 84% for the shared transport. We have 90% for work and 57% for home. So Dr. Evans, what do you say about that?
Okay, these are really very good responses again from our colleagues. And the first one, in terms of shared transport, this is quite correct because it was stated that the case used the hospital bus from 15th to 20th August to travel to work. And this is what he usually does. So it is very important to find out, what are the possible exposures which happened on this shared transport. Where was he normally sitting? Who was next to him in this shared transport? Who are his close contacts around where he was sitting in this bus? And he did that for almost 5 days using this bus from 15th to 20th. So that is correct, and almost all of you did get that one. At work, again, very important, especially where he works in the surgical unit. It's really critical to know who was exposed. What are the exposures which were took place at the place of work for this in this scenario at his workplace. So again, all of you did answer that correctly. He does, of course, have a home, and he lives with his wife and his 3 children. The scenario mentioned a grandmother aged 65, where the kids stayed at home, on the day he was admitted with the grandmother. We are not told whether the grandmother stays with them or came from elsewhere for that particular day, but it is important, that the home environment as a possible exposure where his wife and 3 children are. So all 3 are actually correct. The transport, at work, and at home. All these scenarios about possible exposure are actually correct. Over to you, Paula.
So many thanks, Dr. Evans, and many thanks to all of you for contributing to this case scenario. So it was somehow challenging because, partly because of the speed of the activity. So we are now going to go to the next step with the key messages that will be the key messages, not only about the scenario, but about the entire webinar that will be reviewed by Dr. Evans, I believe.
Yes. Okay. I'm sorry for the background noise. Okay. So the key messages here. So the first bullet point there, contact tracing, isolation, and testing is one important strategy to reduce, COVID transmission. So this has been stated, quite a number of times by our technical colleagues in WHO, that even in the face of community transmission, we still do not stop contact tracing, we don't stop isolating, and we continue with testing. And as even at the beginning, our colleague Traore mentioned that some countries are giving up on contact tracing because they say we have community transmission, but there's still a place for it, and we should still continue with the contact tracing. The second bullet, its effectiveness is heavily dependent on completeness and timeliness of contact tracing activities, and the feasibility of quarantine and the availability of testing. Yeah, obviously, and many countries have faced this issue of, so what do you do with contacts once you have them? Where do you quarantine them? Do you quarantine all of them? And many have now used the home quarantine processes also because of, maybe facility quarantine is becoming difficult. And also, do you have testing available? Many countries really have difficulties in being able to test all the suspect cases because of maybe challenges in testing capacities and all that. But still, as much as possible, we should continue the contact tracing, and we should recognize that for it to be complete and timely, you need to augment it with being able to quarantine either in facility or in home environment, and should be able to offer the testing once the contact is deemed to be a suspect case and meets the case definition. Okay, the third point, it is labor intensive. In limited resources, this is a problem, of course, and in limited resources, it is quite an issue of, just how do you expand your contact tracing activities when you don't have enough personnel to do this. It is costly also, and there are community issues also in terms of engaging with communities to accept contact tracing as because there's issues of stigma involved, and you have to communicate with the communities to accept this method of addressing transmission. So this is having enough human resources, having financial resources, being able to address community perceptions and stigma. These are the kind of challenges which will limit the effectiveness of your contact tracing. But you don't stop, you still continue to the extent that you're able to do this. Over to you.
Thank you very much, Dr. Evans, for these final take-home messages. I want to invite you all participants to, for the last time during this webinar, to take your smartphone and join the evaluation. Actually, we would like to know from you what do you think about the webinar, and what are if it responded to the questions you had when you reached the webinar. There are a set of 5 questions that you can quickly respond to, and this will be helpful for us to really evaluate what has been done today. So Silvio, can we have the evaluation on the screen?
It is normally, I hope so. Oh, okay, let me show in my screen.
Yeah,
okay.
you have to show your screen. So those are quite quick questions, and again, you can just scan the QR code, and it will enable you to respond to the form. And then after that, we will have the closing remarks and the next steps in 2 minutes time. So, okay, we have 30 people connected to the evaluation so far. Please join. We will be really happy to see and to learn what you think about the experience of attending this webinar. Silvio, if we see the responses, will that stop
I don't think so, but it's scared. It is the first time we use this in public. So
Okay, let's leave it like this. Let's give a few minutes to everybody to respond to the 5 questions. Okay. So now we have 63 people who responded. It would be great to have the opinion of the most of the people who had attended. Okay. So I see people asking on the chat box whether the slides will be provided, and yes, don't worry, the slides will be provided, and the record. You will get also a link to the recorded webinar if you wish to look at some parts of it again. And that's one of the points. This will be done through email, and to all those who attended the webinar. And the second point is that whatever question that was raised here and wasn't really elaborated sufficiently, you can continue that discussion on the Rapid Response Team Knowledge Network, and we will provide you with a link to join that network just after, at the end of the presentation. It is there, so don't worry, you will not lose access to the material and the experience of the webinar today. So when we reach the 100, we can probably show the results. Silvio?
yes. Yes, we got it. Okay. Question 1, did this webinar respond to key questions and challenges you encountered in the field? It seems yes.
To most of them. Okay. So
Next one. Please indicate to what extent you agree with the following statement. This webinar enabled me to learn something new thanks to the examples and experiences shared by the facilitators and participants. So not bad. Thank you. Next. So this webinar enabled me to learn and consolidate my learning on methods, principles, and tools for active case finding and contact tracing in the context of the COVID-19 pandemic. Next. Okay. Please indicate to what extent you know, okay, the methodologies and tools used during this webinar were good and facilitated by my active participation. Thanks again. Last question. We see the rate. So we had 5 stars, so 0% for the 1 star. And so we see it's good enough.
Okay. Okay, so we understand that some of you have encountered it a bit difficult to use the Slido, and still you have managed to express your opinion through the chat box, which is good. Many thanks. So that's now the end of our webinar. I want to thank you all for attending. Quickly, I'll show you the last slides where you see some recommended and up-to-date guidelines. So the next steps that we are recalling here, the first one being the community engagement webinar that will take place next week, Tuesday, 13 October, same time. And also for you to know that at the end of the webinar series, end of October, we will, all attendees will receive a link to access the evaluation of learning. And there will be a certificate of completion of the webinar series for those who will complete that evaluation successfully. Successfully meaning more than 80%, at least 80% correct answers. So then the last information here is the way for you to join the Rapid Response Team Knowledge Network. So you can scan the QR code or type the link that you have right there. And it will enable you to join the network and continue the sharing of experiences. I see that some people have their hands raised. Sorry, but we won't be able to take questions live because we have a high number of people that it's difficult to just select 1 or 2 people to do that. So we welcome your any remark through the chat box or even by email afterwards. You have my contact details. You can send any remark that you would like to make. So lastly, we want to thank, of course, the team of facilitators who did design and develop the materials and facilitated the webinar today. And of course, I want to thank you all participants for being part of this webinar. And I wish really to be with you again next week on Tuesday for the community engagement webinar, if you are interested. So many thanks to all and bye-bye. Have a great evening.
Thanks, everybody. You can switch on your camera if you want to show your hands. That would be nice. Thank you.
Okay.
Thank you. Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you very much. Thank you so much.
South Africa is also here. Thank you. Can you share us the link to the WhatsApp?
Thank you.
Thank you from Bhutan.
Please show the link to the WhatsApp, please.
Thank you.
Thank
you so much. Thank you.
Good night from Bhutan.
Oh, excellent.
Tashidelek, Bhutan. Thank you.
Good night, Dr. Sita and friend.
Thank you, everyone.
Thank you. Thank you, everyone.
Good night from India.
For being with us.
Thank you.
Okay.
Okay.
Okay. Thank you. Bye-bye. The facilitators, we will remain online for a short meeting, and then participants, thanks again, and hope to see you next week on the next webinar.
Thank you. Thank you.
Thank you, madam.
Thank you, everybody. And see you soon.